The first CME is going to be on newer investigations in traumatic brain injury research. The chairpersons for this CME would be Dr. B.S. Sharma, Head of the Department of Neurosurgery at the All India Institute of Medical Sciences, and Dr. Raj Gupta. He's one of our international faculty, a Deputy Director and Senior Science Advisor of the DoD Blast Injury Research Program at the U.S. Army Medical Research and Material Command at Maryland, USA. Dr. Gupta is a retired U.S. Army colonel and an accomplished research and development executive with more than 35 years of diverse experience in biomedical research and development. And he has many awards and decorations to his name.
Good morning. We start with this inaugural session on newer investigations in traumatic brain injury research. At the outset, I invite Dr. Maria D'Souza for her talk on advances in novel imaging in traumatic brain injury.
Thank you, sir. As we all know, CT and MR are the cornerstones in the evaluation of acute traumatic brain injury. Yet, there is a good fraction of patients who are neurologically intact, have an apparently normal CT and MR, and yet suffer from persistent symptoms. So the primary challenge is to detect this well-appearing, apparently normal patient who sustained a potentially significant intracranial injury. And the secondary challenge is to identify those patients who are at risk for having prolonged post-concussive symptoms. So the fundamental question before us is, what is this pathology that is so elusive to the clinician and to the radiologist but can wreak havoc in the patient? Brain trauma, as we all know, produces diffuse axonal injury, and that leads to a disruption in the connectivity of key centers in the brain, leading to the persistent neurocognitive deficits. And that's been proven on several histological studies on animals and on post-mortem human specimens, but often gets missed on the CT and conventional MR. And that's where the novel imaging techniques come to the fore. And the most widely available among these is the SWI, or the susceptibility weighted imaging sequence. Now this is based on the paramagnetic property of blood breakdown products. And that leads to areas of magnetic field inhomogeneities, which would be seen as areas of signal drop, which is well seen as these dark areas on the SWI image. So the microhemorrhages produced by DAI are picked up on SWI, even if not on the conventional MR. Of all the techniques that we have today, the best and the most useful to investigate the ultrastructural integrity of the white matter is DTI, or diffusion tensor imaging. Now this is based on the simple principle of diffusion of water molecules in the tissue. So when you place water molecules in a medium which has no boundaries, it diffuses in an unconstrained manner, which is called isotropic diffusion. But if the medium is shaped like a long cylinder, the diffusion occurs preferentially along the long axis of the cylinder and is highly restricted in all other directions. And that's called anisotropic diffusion. And that's the exact situation in our neurons, wherein this longitudinal orientation of the microtubules, the neurofilaments, the cell membrane, and the myelin sheath, all of which contributes to the high anisotropy, or the highly directional diffusion of water molecules. Now this differential property is made use of to obtain different kinds of maps on MRI, and we can quantify it using different measures, the most frequent ones being the ADC, that is the apparent diffusion coefficient, which tells us the magnitude of the overall diffusion, and the FA, or the fractional anisotropy, which gives us an idea about the directionality of the diffusion. And then we have this color-coded FA map, which tells us about the orientation of the white matter tracts. So one of our typical cases of a young patient who had sustained TBI 3 days prior to the MR scan, wherein the conventional MR and the SWI both are normal, but the DTI sequence shows that he has sustained an injury with a paucity of fibers in the region of the splenium and the isthmus of the corpus callosum. Now, studies done across the globe, including those at our own institution, have shown that in the acute phase, there is a reduction in the fractional anisotropy with or without an increase in the ADC. And our studies show that these DTI indices obtained at the time of injury show a significant correlation with the severity of the post-concussive symptoms which the patient experiences 6 months after the injury, thus making DTI a useful predictor of functional outcome. And many other studies have shown a good correlation between these DTI indices and the patient performance in different cognitive domains such as attention, memory, executive function, and so on. Of course, DTI has its limitations, which we won't delve into due to the paucity of time. Then we come to MR spectroscopy, which tells us about the metabolic profile of the tissue. And so far, up to 35 different metabolites have been characterized in the brain, but routinely we are looking at N-acetyl aspartate, which is a marker of neuronal integrity, creatine, a marker for energy metabolism, choline, a marker for membrane disruption and synthesis, lactate generated through anaerobic glycolysis, and glutamate, an excitatory neurotransmitter. So this is one of the typical MR spectrum in our healthy control, wherein you see this high NAA peak and a very small choline peak. Now, MRI studies in TBI have shown that there is a disruption in the neurometabolite profile even in mild TBI, and this has been observed even at sites remote from the actual injury, thus corroborating with the histological observations of diffuse axonal injury. And the majority of the studies have shown a drop in the NAA levels with a rise in the choline levels with or without a rise in lactate, glutamate, and creatine levels. And it has been seen that these NAA levels are predictive of the long-term functional outcome in the patients and show a good correlation with neuropsychological tests. So one of our typical case versus control, wherein you see the TBI case showing a very small NAA peak and a high choline and inositol peak. MRS2 has its limitations. We move on to fMRI, which is based on the BOLD principle, that is the blood oxygen level dependent imaging. So we make our subject perform a task, usually a mental task, and that leads to a selective activation of certain centers in the brain. And this increased neuronal activity leads to increased blood flow. The oxygen supply outstrips the demand. And because of the differential paramagnetic properties of oxy and deoxyhemoglobin, there is an increase in the overall image intensity in that area. So we can activate different regions of the brain by making the patient perform different kinds of tasks. But the kind of task which is generally used in the TBI studies have been the working memory tasks, and the most popular paradigm is the N-back task design, wherein as you go from the 0 back to the 1 back to the 2 back tasks, your task goes on increasing in complexity. So this is one of our typical surface rendered fMRI images of a patient performing a working memory task, wherein you can see the activation of the bilateral prefrontal parietal lobes of the brain. And the pioneering work on fMRI in MTBI was performed by McAllister and colleagues. They found that in healthy controls, as you increase the task complexity, going from the 1 to the 2 back and then to the 3 back, there is a monotonic increase in the bold activity. But in TBI patients, there is surprisingly a very high activation in moderately difficult tasks, that is from 1 to 2 back. But paradoxically, when you move on to even more complex tasks, that is from 2 to 3 back, there is very little activation, a very little increase in the bold activity. So the interpretation for this is that at moderately difficult task loads, there is an additional neuronal recruitment in order to perform that task, whereas at highly complex tasks, there is no additional resource allocation. Another similar study between the controls and a cohort of concussed athletes showed additional activation of more neuronal centers in a working memory task, again suggestive of compensatory recruitment of additional networks in order to perform that task. Now, although task-based fMRI has been the cornerstone for our understanding of brain function, there is increasing interest today in resting fMRI. And this fMRI, which is performed at rest, has the advantage that you don't need the patient's cooperation in order to perform the task. And so you can use it even in the acute TBI setting. And additionally, you can study multiple neuronal networks simultaneously from just one data set. And out of these networks, the most fundamental of these is the default mode network, which gets activated when the patient is at rest and not concentrating on the external environment. And opposing this network, you have the task-based networks like the somatosensory, visual, auditory, language networks, and so on. So in MTBI studies, it's been found that there is a decrease in connectivity within the default mode network, which is seen as these blue areas, with a hyperconnectivity with the task-based networks seen as the red areas. fMRI has its limitations primarily because bold is a hemodynamic response and not a direct measure of neuronal response. So combining this with more direct neural measures like EEG and MEG are currently under investigation. Now we move to the nuclear medicine techniques, SPECT and PET. SPECT uses tracers to assess the cerebral blood flow based on the radiotracer distribution, and it has been seen that there is focal hypoperfusion at and near the site of injury with asymmetrical diffuse hypoperfusion in the frontal and parietal lobes and basal ganglia. Unfortunately, it is not specific because comorbidities like alcohol and drug abuse also produce the same pattern. But having said that, SPECT has a high negative predictive value in that a negative SPECT scan heralds an excellent prognosis. So one of our typical cases wherein you see the intraparenchymal and the extradural bleeds seen as areas of hypoperfusion on SPECT. SPECT has its limitations because of ionizing radiation and its low specificity. PET is much more sensitive. The radiotracer here is FDG, which is the workhorse of PET imaging, and it shows global and regional hypoperfusion, especially in the frontal and anterior temporal lobes, which correlates well with the neurocognitive profile of the patient. But it's important to be cognizant of the fact that neither SPECT nor PET are by themselves diagnostic. They're only corroborative tools. Again, a typical case showing hypoperfusion in the orbitofrontal cortex. Now we have O15 water PET, that is radio water, which has a half-life of just 2 minutes, and it's a rapidly diffusible tracer. So areas of the brain where there is a high tracer activity would be having increased blood flow in the tissues in that region. So you can use a radio water PET just like an fMRI study, and here the same subject is performing a visual task on both techniques. And here again there has been seen a compensatory recruitment of additional neuronal centers in the brain in response to a memory retrieval task in patients with TBI. Now, so far there has been a few hundred studies on TBI imaging, but unfortunately there is a vast heterogeneity in the study population in terms of the injury mechanism, the injury severity, the duration, which ranges right from 2 days to up to 15 years, and of course in the demographic profile of the patient. and there is an equally vast heterogeneity in the methodology of the study, both in terms of the data acquisition protocols and the data pre and post processing. So the major challenge which lies before us is to standardize these acquisition protocols and image analysis platforms so that we could do away with this heterogeneity. And secondly, to translate these biomarkers for routine clinical use. So although these novel techniques have been vital tools in our understanding of the pathophysiology of TBI, they are yet to make their way into the routine clinics. And what can be the potential impact or the low-hanging fruit that you could obtain from these techniques on our clinics, on our patients? To my mind, the most promising of these tools is DTI because it's widely available on every standard MR scanner today. It takes just an extra 6 minutes of scanning time. But the big challenge here would be to develop softwares which could rapidly and accurately analyze the data and present it to the clinician for appropriate management. It's only then that we can make a real difference to our patients. Thank you.
The paper is open for discussion. If there are any questions, you will be happy to answer those. Yeah, the paper is open. Yeah, please, Dr. Mashchandra.
I really appreciate what you said. It's an excellent talk, and the question I was thinking was in terms of mild. One of the difficulties is actually the repeated mild. Have you had any cases where the second or third, the repeated ones, intensify what you're observing in the first, or is it completely different?
Actually, sir, unfortunately or fortunately, we have not come across any patient who came to us with a second injury, but there is a lot of information in the available literature, and that applies especially to the soldiers at war and also to the athletes who undergo repeated concussions. And what's been observed is that the second and the third injury are definitely much more damaging than the first, both in terms of the patient profile, his symptomatology, his neurological deficits, and also as far as imaging is concerned, there is an aggravation of the abnormalities which we are already seeing. Like on TBI, we find that there is a further fall in the fractional anisotropy and the mean diffusivity increases in these patients. And also they have also done MRS studies which also show a further worsening of the neurometabolite profile. So every repeated injury is actually causing more damage, which is becoming very obvious on the scanning as well as in terms of the actual patient evaluation for the clinician.
Just to follow up, is it the same regional dysfunctions, or is it completely in different areas? Is it spatially intensifying what you're observing the first hit, or is it continuously changing in new locations?
Okay, so actually when we talk about a regional dysfunction, are you referring to what we're seeing on imaging? Okay, right, sir. So on imaging, even in the first injury which a patient sustains, it's not just that regional damage which we see. That can be picked up on a conventional CT and MR as a coup and a counter coup injury. But that diffuse axonal injury actually produces diffuse changes even on his first hit. And subsequently this only worsens. So I think both times, whether it's the first or subsequent ones, there is a diffuse involvement of the brain, which is picked up on all the imaging modalities.
Okay, thank you very much. Now I invite my co-chair, Dr. Raj Gupta, for his talk on multi-slice modeling of blast-induced traumatic brain injury from whole body responses to brain microdamage.
Okay, good morning. First of all, I'd like to thank the organizers for inviting me and giving me this opportunity to share some of my thoughts about multi-scale modeling of blast-induced TBI. And the title of my talk is Multiscale, not what is printed in the in the program, from whole body responses to brain microdamage. And I like to point out that the views, what I'm going to talk about today and what I say is views expressed in this presentation are those are mine, and they are not necessarily endorsed by the US Army or Department of Defense. And I'd like to also acknowledge thank some of my colleagues at CFDRC for running some of these simulations, which I'll be discussing during my presentation. Okay, today what I'm going to be talking about, I'm going to go into a little bit introduction in what is the US DoD blast injury research program investment or current gaps we think we are trying to address, then go into a little bit about the non-impact blast induced mild TBI, and what we know, what we don't know, and what we are trying to get to. And then I'm going to introduce multi-scale modeling concept which we are trying to work at. And then go into a little bit about macro scale primary blast TBI, and then get into micro scale, and then I'll conclude with some of the challenges I would like to share with you. As you know, that because of the advances in modern medicine and some of the personal protection devices, and especially, you know, earlier this morning when we had the opening session, Dr. Sharma and other folks had mentioned about use of helmets to protect against a traumatic brain injury. Some of those things we actually have used in the military settings, and they actually, soldiers are surviving. So and we attribute those survivability due to advances in modern medicine and proper wear of personal protective gear, as well as evacuation and the care which is provided by the physicians and the attending surgeons. Say for us in the military, the challenge is a little bit different. Because we have the blast-induced TBI, which is very different, or which may be different than the impact injury which you normally see in traffic accidents. But however, we think that the primary mechanism may be very similar, the way the brain injury is caused. What is causing the changes in our philosophy is because of the type of casualties we are having, especially injuries to the brain, and also the increase in amputations and other trauma which is related to blast or the impact injuries, and then that leading into the post-traumatic stress disorder. And this slide pretty much shows bottom line is that most of the traumatic brain injuries we are seeing are attributable to mild traumatic brain injury, which is one of the areas I'll be talking about. To just get you a little bit of background on where we are in our traumatic brain research, current investment, most of our focused research in the DoD started out about 7 to 8 years ago, around 2007 or so, based on the casualties we were seeing, and then also the knowledge gaps we understood at the time. And this slide actually lists some of our investments where we are actually have a multi-pronged attack, where we're trying to understand the basic biology behind the blast injuries. At the same time, we are looking into the diagnostics, treatment, surgical avenues, and also how does it affect the a human being after is exposed and how the rehabilitation. So it's quite a few different approaches we are taking at the same time. Now I'll be focusing on non-impact blast-induced mild TBI. Pretty much what happens, as most of you know, one of the knowledge gaps we have is that we don't understand what is the mechanism of the mild TBI. There is no consensus in the scientific community as far as we know. And there are multiple theories or injury mechanism proposed, and I've listed some of them on the slide here. And some say, well, injury is caused due to acceleration, rotation, or it may be due to microfracture of skull, or it could be something we call vascular surge, where a blast wave comes and hits the body around the chest cavity, and then you have a vascular surge going into the brain and causes MTBI or the injury, and it could be because of cavitation. So there are quite a few different hypotheses, mechanisms out there, but pretty much we still don't understand what is the real cause of the mechanism of this injury is. Now coming into the way we think is that this TBI injury is a multi-scale injury. It's not a very simple injury. There are different time scales involved here, and there are multiple factors involved here. One of the things is that when we're talking about a blast wave coming and hitting a human body, the shock waves coming in, they are terms in microseconds. They are impacting the human body. And whereas if you are dealing with the impact injuries or the automobile or the motorcycle type crashes, you're talking about in hundreds of milliseconds compared to millisecond. And then the shock wave comes and hits the brain, and then it causes integrated pressure wave, which could be in milliseconds, and then by the time it transcends through the body, you're talking about into seconds, and by the time it causes secondary injury, it could be seconds, minutes, hours, days, weeks, or years. So we really don't know what is the real time frame. And we have seen symptoms which appear right away, and then we have seen symptoms which come months and years later, and it actually affects the performance. Let's see. And then along with the time scales, then you're talking about the length scales. Blast in a human body, how is that interacting? How the human body interacts with the blast wave or the impact? And each human being person is very different. So each human actually reacts very differently. And it also depends on the way the angle of the exposure and what is where the injury is being caused. And some of the things I hypothesize that maybe it's an external injury, which could be talking about micro milliseconds, and then you're talking about synapses. So there are a lot of information and a lot of approaches, and this slide sort of summarizes a multi-scale modeling framework which we are trying to develop. What we think is that first thing there'll be multiple models within this framework. One of the initial models, you have to be able to analyze the threat, or you have to be able to calculate a loading scenario or the threat, and then which will become part of the loading model, and which we can tell us what is the impact of the blast without debris or with the blunt or blast, fall or crash. And then also input to this model would be a body posture model, which is going to be able to tell us, okay, if a certain person is wearing personal protective measures, or in case of automotive crashes, if a person is wearing helmet, or then what type of effect that has, and that's going to lead into some sort of a dose which is going to be actually causing the biomechanics or biodynamics or biomechanic injuries. And then as you go through it, based on the anatomy of the human body, the pathophysiology, and the personal protection equipment which is wearing, hopefully you will be able to determine what the injury criteria or what is the probability of the injury is. Our main aim here is we're trying to prevent injuries which are preventable. So we want to understand and try to design the protective equipments to prevent the injuries before they actually happen, because once the injury happens, then there is nothing we can do. Get into the medical system, and pretty much you can diagnose the injury, treat it, and then try to rehabilitate. One of the mandates we have is that we are trying to bring service members close to the conditions they were before they were injured. I think, looking at the time I have, I think I'm going to skip through some of these slides. Basically, this slide she's showing is that we are not trying to do all of the research in this project. What we are trying to do is leverage as much as possible from the existing knowledge, and then collaborate with other partners in the other government institutions, academia, international partners, or wherever, or the industry. So we are trying to leverage the information wherever is available and trying to collaborate with as much as possible. And one of the other things which makes all of this effort complicated is the difference between the studies we do in the lab, or the conditions we can create in a laboratory compared to the open field blast, or actually the exposure which happens in the field. And there is a big difference, and there have been quite a few efforts going on where we're trying to create injury which is similar to what is caused in the field scenario or in open blast exposure. And then one of the other factors also into consideration is the blast pressure loading in the, how does the blast actually transmits or transcends through the human body, which way it goes, and what type of injuries causes, and is that a complication of inertia, or is another type of force. This is a slide just showing some human body biomechanics caused due to the primary injury. And if you look on the left top corner, what this set of figures are showing is that as the blast wave is hitting the human body, how does it transfers or move through the body. And the red color is probably the most damaging, or the high blast wave compared to the other colors. Now coming into micro injury, one of the things is a lot of folks, or most of the scientists thinking that it causes external injuries, which have been proven, and a lot of studies have been done. But I think in our opinion, the external injury is only part of the whole equation. There could be something happening at the synaptic, or the synaptic injuries being caused, or which causes the interruption of the synaptic, or means chemical signal transfer between the synapses within the brain. And then it could be because of the blood-brain barrier changes, or it could be vascular damage. And a lot of these things are right now unknown, and we are hoping that as we move forward, we try to either understand this, or as we gain knowledge, or discard some of these theories, or prove this is what is causing the injury. And one of the missing point here is that we have a lot of models out there, but what all of those models, most of them need is the validation. Okay, yes, I want to continue. Mr. Chairman, okay, I think it's going to take a couple of more minutes to summarize it. And this slide is a little bit complicated, but it shows is that there are some work ongoing which is trying to create simulations in the laboratory to cause injuries similar to what happens in the field environment. And then we are also trying to work on animal models, and their main effort is trying to cause injuries or try to replicate injuries in an animal model which is similar to a human being. And okay, I think I'm going to skip that. And I would like to focus on some of the challenges where I think you may be able to help us. The challenge is we want to be able to define what blast level exposures we need to cause and replicate injuries similar to humans in an animal model. Our thinking is that if we have an animal model, then we probably be able to speed up a lot of the experiments and other things, and we may be able to get to the bottom of the root cause or the mechanism of injury in a expedited manner. And we also like to develop some objective methods and validated instruments where we can standardize experiments across laboratories, and for the main reason for compiling data, pooling the data, or cross-validation of results. And then hopefully all of these things will lead into establishing some thresholds. Means that threshold means this is the minimum force which will cause injury in a human being, and if we can protect that human from exposing to those type of blast forces, then we may be able to prevent injuries. And this is some of the recommendations we have. If you're working in the laboratory, we would like to you to share computation models you're developing with other modelers, and all exchange test data with your colleagues, and try to conduct whole animal experiments compared to doing some on a singular cells levels, or that. Main philosophy behind is that the whole animal actually you may see a different type of injury than if you're looking in the cellular structure. And what we're trying to do is create some sort of a minimum standard for DoD-defined animal studies designed to validate and the computation models. And also, while doing that, to develop some benchmarks, especially the loading paradigms. And in the end, we are hoping is that by the time we finish our efforts, we'll be able to establish multiple animal models that can reliably address the questions we want to address concerning blast-induced injuries. I appreciate. Thank you for your attention. And
thank you, Dr. Gupta. Because of paucity of time, we will not have questions this time, but if you have any doubts, you can discuss with him in the tea time. Now, may I invite Professor A.K. Mahapatra for his talk on optic nerve injury guidelines, clinical diagnosis and management guidelines.
Can I have slides? Slides? Are they putting from there? Are they putting slides from there? Good morning, chairperson and friends. I developed interest in optic nerve injury in November 1983 when I saw Mr. Suresh Babu from Kerala, who was working in Delhi and sustained optic nerve concussion. And I had no clue about optic nerve injury. From that day, 22nd November 1983 onward, I did a lot of study to establish the pathology, radiology, Vibhav potential, management protocol and outcome of optic nerve injury. So this study, which I have been working on for last 35 years or so, if you go back to history, the head injury and optic nerve injury is as old as humanity because a human being cannot survive without trauma. So Hippocrates said the blindness occur in any injury just above eyebrow because that is the long axis optic nerve and that's what he said de moris vulgaris. So the question of diminution of vision occurs after the injury occur over the eyebrow. That we know for a long time. Any injury as it happens to human body, it can be closed or it could be open. When I started my study in a protocol based in last 33 years or so, we found the literature very scanty and there was incidence which can range from as low as 0.6% to 5%. My protocol on best, what we have seen, it is about 2 to 5% or 3.5% or so. And if you take a study from the India, 2 million people get accident every year, we calculate about 25 to 30,000 people get optic nerve injury every year and cumulative effect, you can have millions of people those who become blind because of optic nerve injury. And how do you classify them? Any injury can be classified as immediate or late, depending on how the pathology started. It is unilateral or bilateral. It could be primary damage, that is what happens due to injury, or the secondary damage which happens because of ischemia, hypoxia and other secondary damage. So optic nerve has a 40 millimeter length and 4 parts. That's part 1 is intraocular part, intraorbital part, intracanalicular part and intercanal part. And the injury happens more frequently at the optic canal level because periosteum of the optic canal is fixed to the outer sheath of the optic nerve through which the small blood vessels traverse to the axons of optic nerve. So what does happen? When the optic nerve, when the long axis of optic nerve anterior-posteriorly, there is a shearing strain because the optic nerve is fixed in the optic canal through the periosteum of the skull. So there is a shearing strain, rupture of the vessels and there are microvascular thrombosis. This is the basic pathogenic mechanism of ischemic optic neuropathy following head injury or injury to the head. So it could have, if you look at the literature, what can happen because of this pathology which is shearing strain to the blood vasculature of the optic nerve at the optic canal. It can cause fracture of the optic canal which is around 35%. It could have PNS injury, it could have optic canal fracture seen in CT scan up to 12 to 15%. It could have orbital hematoma, optic nerve hematoma and MRI shows about 50% more abnormalities. If you look at the visual evoked potential, why I am only focusing on the salient point because what I did in last 35 years cannot be spoken in 15 minutes. I started doing visual evoked potential day 1, that is 22nd November 1983 and found a person who has lost optic nerve vision had positive visual evoked potential. That gave an impetus that even a person is physically blind, he still have conduction to the axons of the optic nerve fibers. So when I look at the literature, there are very, very few case reports including 1 to 5 cases which is published 1973 and 1982. Then I did hundreds of cases. In 2007 I calculated number 987. After that I have been out and in from this institute, not able to keep. I have seen around 1200 cases of optic nerve injury and I have seen many cases in other countries and all this. Unfortunately, our own resident and people across India do not recognize optic nerve injury. They always confuse between second nerve and third nerve. What happens to the damage to the optic nerve may be shearing strain, may be axonal injury, may be ischemic neuropathy, what may be caused, but the maximum brunt is on the nasal fibers of optic nerve where the fibers get maximal damage. So it affects the temporal field, and if you look at this chart, you see the maximum number is the temporal field cut. But there could be very bizarre field cut depending what type of axonal damage happens during the injury process. So the factor what has influenced the outcome. Factors could be complete damage to the visual pathway, partial damage. These are factors of significance. So if a person has optic nerve injury, the partial or complete BEP positive or negative, complete visual loss or not complete visual loss, optic canal fracture or no. There are a lot of factors which influence the outcome. Now you see the real factor of significance, immediate visual loss or delayed. If it's delayed visual loss means the nerve could not have been damaged at the time of injury. So there is something happened and after some time of injury, so that patient was be able to see the things and then become blind. So this is very significant. So it is not an immediate type of then you have to have what happens to the intervention, and presence and opening of canal fracture is not a very significant, so it is not important. If our experience, we have seen children have less chance of recovery. The reason may be the axon get damaged and they don't recover. Adults have better recovery. Unilateral injury has worse recovery than, because when the force of impact is the forehead, if it has to be going through the both optic canal, the force of impact becomes half. So if you have unilateral injury, entire force of impact travels to the single optic nerve. So the single optic nerve get damaged much more than the both sides. But if the forehead midline injury, the force of impact travels to both optic canal, the chance of recovery. So if you have a chance to have optic nerve injury, pray God, it should be midline the forehead. So we have bilateral injury and get both side recovery. So blast and firearm has a poor. I have large number of patients, shotgun injury, they have a very poor outcome. And my visual evoked potential study have shown that PL negative, we do at least 3 to 4 visual evoked potential from day of injury or as the time patient comes in past 3 weeks. And we can reach 3 conclusions. The conclusion is that initially visual present and improve and normalize. Initially visual evoked absent, it started improving and improved. Visual evoked potential can remain negative, and negative. So if it remains negative, and negative, chance of recovery is almost 0. So what are the controversy existed in the literature? The pathogenesis of visual damage we do not know. Role of steroid, there is no clue in 1980s, and indication of MRI CT was not known in 80s, and indication for optic nerve decompression was not known, or time of surgery was controversial. That is the reason from Boston, the Eye and Ear Infirmary, Michael Joseph started study in 1993, International Optic Nerve Study Group, when 33 centers participated, and we are the only center out of US. There are 32 centers from US, and we are the only center across the world out of US. So we contributed 35% in 2 years out of 255% prospectively studied by Michael Joseph. So our protocol is that patient evaluation, repeated VP studies, it may require 5 studies in past 2 to 3 weeks. Steroid given initially intravenous, then oral, then regular evaluation of both clinical, electrophysiological to see the improvements. So what are the criteria I laid down? I told that we should follow this patient regularly with corticosteroid past 3 weeks. None of the patients are operated if there is no indication of surgery. People always argue, subject every patient for surgery. It's foolish. Every nerve injury doesn't require operation on day 1. You have to give a chance for macular recovery. If the patients of progressive improvement, there is no indication of surgery. If the patient who start improving and then stop, then you can operate. If the patient remain PL negative, why do you are operating for? So the principle of surgery is that a patient progressively improve, no surgery. If a patient improve partially and then remain static, operate. If a patient not improving, visual potentials are negative, there is foolishness to operate. Though we had a lot of cases, this was 2007, I have not added all 300-400 cases or 500 cases which I have seen, but what remains the fact that 90% people lose their vision immediately and 85% are unilateral. That's good luck that the 85% are unilateral. Role of visual evoked potential, if it is repeatedly normal, the person has to develop some improvement. I am not talking that if a person has normal visual evoked potential, 100% will have 100% recovery. Don't misunderstand. Every word has meaning. 100% people will show some recovery if they are positive, repeatedly positive evoked potential. And if it is repeatedly negative visual evoked potential, 100% will have no recovery. So there is no point doing any operation. But somebody is abnormal and showing vision improvement, but not satisfactory improvement, then he will require an operation. So this is what has happened. Overall improvement in our study at different time is around 55 to 58%. However, complete recovery only occurs in 10%. And mind it, this complete recovery only occurs in conservative treatment. No surgery can ever improve from very 1 by 60 or 2 by 2 to 200 by 20 to 200 by 200 or 20 by 20. So the partial recovery can happen only in 48%. So if a person has to have complete recovery, surgery is very little role. That means there is a subsection of the patient, those who develop optic nerve concussion, and they do not have complete damage to the optic nerve axons. Thereby, their chance of recovery is about 100% and no role of surgery. You have to have patience and wait and watch. So what is about idea about evoked potential? I have already told. Do you think that every patient requires CT and MRI? I have started after treating about 1200 cases of optic nerve injury. These are superfluous. Because if a person has hematoma, so what? If the damage has happened. You are removing the hematoma is not going to make any difference. If the axons have damage. If the optic canal fracture, so what? Doesn't make difference. You go and put the fracture segment, you damage whatever little axons are damaged there. So rushing for an CT and MRI is not important. But it is important to understand that your operation should be planned such a way that it helps the patient rather than whims of the surgeon. What we have gained in last 30 years or so, we have established the role of BEP. BEP is a very, very, very important tool to diagnose positive BEP, negative BEP, positive BEP become better and better and become normalized. We have also told the CT scan is helpful to see the other parts of damage to the paranasal sinuses, brain, occipital or other things. Not very important for establish the pathogenesis of bilateral injury. I published about 35 papers between 1986 and 2010, and I have one series in the world literature, bilateral optic nerve in 30 cases, and I established what are the pathogenesis mechanism of bilateral optic nerve injury. We found various prognostic factor, whether it is age, type of injury, blast injury, shotgun injury, evoked potential. So the large number of factors we have put down what are the good or bad prognostic factors. We also have role of optic canal fracture. Optic canal fracture is not like a moving fracture of the limb bones that it moves and cut the bone. So canal fracture is significant so far the impact, force of impact. But treating the fracture is not significant. Your treating or not treating is not going to make any difference. So you have to understand the fact that canal fracture means a severe type of injury. Not necessarily treating the fracture will cause improvement. So what is the consensus today? Consensus is that steroid has role. Yes, of course steroid has role because there is some edema around the optic nerve sheath. It can improve the microvascular circulation. VEP is also useful, and some there the indication surgery we have streamlined. If you look at the literature, question is asked, why don't operate? Look at the literature where the patients are conservatively managed from 1951 to 2007. The improvement can occur between 29% to 100% depending on what big series you talk about. But if you take large series, it is some around 55%. This is conservative management. Now go to surgical series. The result of surgery starting from 1960s, 1970s, 80s and all this from Japan, from US, from other India, from other countries, it's between 51% to 70% depending which series you are talking about. But if you look at the Fukado series of 800 cases, this was written in the book called The Cranial Nerve by Geneta and Sami in 1985. When they were looking at the series of Fukado from Japan, they found 300 patients studied and approximately improvement after surgery is 40%. So the question is that why do we become emotional if you understand the world literature today, what is the role of conservative versus surgical management? So this is Fukado series. Look, people argue why not early operate. He operated within 7 days, 43% recovery. He operated 8 to 15 days, 43% recovery. All these if you look at the recovery rate between 39 and 43%, whether you operate day 7 or day 90, it doesn't make any significant difference. So the question is that you have tremendous scope for conservative management of optic nerve injury without being emotional and typical surgical attitude that I will cure everything by surgery. Leave that attitude, manage human being as they are human beings. This is our last few cases between 2004 and 2007, and the inference is almost identical. Whether you treat 500 cases, 700 cases, or 1000, after you have got a significant numbers to guidelines, we understand. So recovery bilateral is better than unilateral. This I wrote a paper in Neurology India. The pathogenesis that if you have a hit in the midline, the force of impact goes to both eyes divided to half. If you have here injury, then all impact goes in one side, the damage to the individual optic nerve. 1 minute more, let us conclude. Can I have next slide? So these are the things we have told. Children have poor recovery. The factors I have already spoken. So what is the steroid? Yes, megadose or low dose doesn't make difference. Oral or injectable doesn't make difference. Dexamethasone, when I was doing study with US giving dexamethasone, and they did not agree for methylprednisolone, but they conclude the methylprednisolone or dexamethasone, no difference. Our protocol is clinical evaluation, BP, CT scan, steroid followed by oral steroid. Thank you very much. I think.
Thank you, Professor Mahapatra, for nice paper. Now this is open for discussion. If you one or two questions.
I did not intentionally talk about 150 cases we operated. I thank my ENT colleague. He is going to talk about operation. We do operate based on our protocol or indication for surgery, not blindly operate everybody who comes my way because my knife is ready for surgery. Any question? I hope that I have cleared the doubt. My greatest pity is that after I have been speaking for last 30 years, no second person talk about optic nerve injury in this country. I am the only person who harps that vision is as good as life, and life without vision is terrible. Understand this. Thank you very much.
Thank you, Professor Mahapatra. And now it's my pleasure to invite Dr. Alok Thakur to present his talk titled Optic Nerve Injuries, Recommendations and Surgical Tips.
We have collaborated
Dr.
with the ENT department, so I have left him for service.
Thank you, sir. So, as in the usual situation that we work in, we take over after Dr. Mahapatra has left. So after Dr. Mahapatra has done the medical bits, comes our role. And as Dr. Mahapatra has just emphasized, it's not very frequent. So oftentimes these patients get medical treatment and do reasonably well with medical treatment. And it is the patients who don't do so well with medical treatment who come to us. So really I was asked to speak on recommendations and surgical tips, and I simplified a little bit on why we should be doing this and how. So much of what I have to say has been said by Dr. Mahapatra, but I'll reiterate a little bit of it. And so yes, few options on how you should be treating these injuries. You can treat them by doing nothing and waiting for spontaneous improvement. There is a school of thought which believes in that. And then of course you could look at steroids and you could look at urgent surgery. And the data, if you look in the literature, is not quite conclusive to this day. But nevertheless, the few major studies that I have tended to quote or look at are this one, which was a meta-analysis, which looked at no treatment versus treatment with steroids versus treatment with surgery or versus treatment with medical and surgical treatment. And the conclusion really was that no treatment was not as good as treatment, but which treatment to do, there's no conclusive data on which is better. There is the other study which Dr. Mahapatra talked about, the International Optic Nerve Trauma Study, which was the one that we were part of. And this one actually went on to say that outcome was no different with or without treatment. But if you look at this study, you really shouldn't be taking this too seriously because there were hardly any patients who had no treatment. And really this study is not powered to answer the question or to make the conclusion that it makes. So you shouldn't be looking at this study very seriously. And now there is a Cochrane review which came out in 2005 and reviewed in 2009. And if you just look at the last line, then it says a trend for surgery to be offered to patients with worse visual acuity. So certainly patients who are worse are often routed to surgery. But at the end of the day, there seems to be no great consensus or evidence to indicate that surgery or immediate surgery is indicated in this situation. So, Dr. Mahapatra obviously was doing all of this even before this evidence came through. So we are looking at medical treatment, and this institution has always looked at medical treatment, and we as surgeons who undertake this operation are very much in sync with that. So yes, initial treatment is medical, and as Dr. Mahapatra said, we do surgery only when medical treatment doesn't work adequately, and we have a very arbitrary line as to where we decide that surgery may be indicated or patients haven't improved adequately, and that arbitrary line is set on what is the definition for legal blindness, which is that visual acuity is less than 6 by 60, or fields are less than 20 degrees. And this is one of our papers with Dr. Mahapatra, Dr. Tandon, and I. Now we were involved with very early in 1994, wherein on Group A we have patients who had surgery who had medical treatment followed by surgery, and in Group B we had only medical treatment. And it just goes to show that though initially medical treatment is what you should be doing because it's safer and just as efficacious, but if you combine surgery to medical treatment in the non-responders, then your overall response rate tends to go up. So the overall improvement rate was 74% in the patients who had salvage surgery, so to say, while it was only 51% in the patients who did not. And this paper continues to be quoted and really is what we have based our practice on. So yes, initial treatment is medical, and surgery sooner the better, but it doesn't have to be immediate. And you today, with MR being available, tend to do an MR for patients, at least all patients who have fractures, before you take them up for surgery, because now and then you find the patient who has an optic nerve injury and a superadded carotid injury, which is right next to the optic